We have intervening tissue, we call them as bridging tissue, we call them as isthmus. So it's roughly located in the front of the neck, in top of this particular trachea, which is basically the windpipe, and this particular thyroid gland is occupied in that particular neck space. We call them as muscular triangle. Now this thyroid gland having got two coverings, two layers. We know that basically about these layers, but I'm just like brushing it quickly. So it has the two layers to cover. We call them a superficial fascia of the thyroid gland, or superficial capsule or external capsule of the thyroid gland, and then it has a deeper capsule or deeper layer. We call them as deep capsule of the thyroid gland. The superficial one is related to the superficial fascia or superficial part, deep capsule or true capsule of the thyroid, which is basically the deep fascia of the neck, which is investing layer. Now the feature of this particular deep capsule or true capsule of the thyroid gland is that this particular true capsule, which is blending the thyroid gland, which is blending and covering like this, and this upper part of this true capsule is anchored to this particular ligament, which is lying, or this cartilage which is lying over here, which is known as thyroid cartilage. Now this particular capsule, which is wrapping up this thyroid gland, which is true capsule, which is anchored to this particular thyroid cartilage, we call this as a ligament of Berry. So that particular has a special term which is noted as the condensation of thyroidal deep capsules or investing layer of the deep fascia. We call them as ligament of Berry, B-E-R-R-Y. Now that particular ligament of Berry is anchoring this or wrapping this particular thyroid gland and moving up and anchoring to this particular thyroid cartilage or the larynx of parts of the larynx skeleton. Now what happens with that? Whenever you are swallowing any subject like drinking or chewing, after that we have to swallow. So once you swallowing, that happens over here with swallowing, this particular thyroid cartilage along with this larynx moves up. So as a result of this particular thyroid cartilage and this particular larynx moves up, when you are swallowing, this ligament of Berry also moves up. As a result of this ligament of Berry moving up, which is anchored to this thyroid gland, this also moves up. So because it is tagged to this particular thyroid gland, the ligament of Berry to this higher end of the ligament Berry is on the thyroid cartilage. As this thyroid cartilage move high, this particular thyroid gland itself pulled up along with the thyroid cartilage whenever you are swallowing. So this particular swallowing nature of this, or this particular swallowing feature, I would say, is present with this particular movement of the thyroid gland upwards. So we just ask you during examination, why this particular thyroid gland moves up with swallowing. So that's a feature, because the thyroid gland itself is not related to the laryngeal cartilage, rather it is sitting below the larynx. But the larynx moves high when you are swallowing. So there is no point the thyroid gland itself should be moving high. But we see that the larynx is moving up, so this particular thyroid gland also moves high whenever you are swallowing. So how these two things can be related anatomically when this thyroid gland is moving high along with this particular larynx is that the thyroid gland is wrapped around by this true capsule, which has a upward continuations which is known as ligament of Berry, which is anchored to this particular thyroid cartilages. Now thyroid cartilage is a part or component or skeleton of larynx. Now whenever we are degluting or swallowing, this larynx or the thyroid cartilage moves up. As this thyroid cartilage is moving up, whatever is bound to this particular thyroid cartilage also moves up. What is bound to the thyroid cartilage is that through the ligament is this particular gland. So this particular gland also, whenever you are swallowing, moving high. So these things need to be explained whenever you are giving this particular explain why kind of question. Now why this particular thing is important to us, why this particular things not just any random phenomenon. This movement of the thyroid gland whenever you are swallowing, which is popping up, is been examined during the clinical examination of thyroid gland. So, if this particular midline swelling you are suspecting of arising of thyroid gland and you are not very sure, that can be ascertained or that can be assured by clinical examination. So, if you have a midline swelling like this of the thyroid gland, for example like this grandma has a huge thyroid gland. So, this particular thyroid gland swelling, if you are saying this is kind of coming out of thyroid swelling. Now, how you can be clinically sure about it? So, you ask this patient to just like a swallow or deglute, and as this person or as this patient is swallowing, this particular thyroid gland should be moving high along with this particular thyroid cartilage. So, this gland, if it is a thyroid swelling, should be moving high along with this swallowing. And if you are not very sure, again you can put a finger on this particular thyroid gland and ask the patient to swallow, and then you can just like visibly and as well as on examination or palpation as well, by palpating as well, you can just see that the thyroid gland moves up with the swallowing. So, this is what the clinical examination is thyroid gland is like. So, that is what we have to keep in mind regard to this particular fascia of the thyroid gland or capsule, true capsule, false capsule, or superficial capsule, deep capsule, like that. Deep capsule is the true capsule, which is the investing layer, which is having pretracheal layer of the investing layer is wrapping on it. This particular thyroid gland is sitting on the trachea, but because its particular thyroid gland is linked up with the thyroid cartilage by the ligament of Berry, whenever this particular thyroid gland is swollen, whenever this particular swallowing, whenever this particular larynx or voice box is moving up, this particular thyroid gland also moves up. Along with that, this particular thyroid gland has a general feature like this part we call them as lateral lobe, right side, left side, two lateral lobes are there. Between them joining tissue, we call them as isthmus. It looks like a H letter, which is looks like it. Now, if you just describe this particular like a lateral lobe, this particular lateral lobe has an apex, has a base, roughly it has a triangular structures or pyramidal structures, has an apex upwards, base downwards, and it has got like surfaces. This surface we call them a superficial surface. It's covered by the muscles which is lying in the front of the neck, which we call them as strap muscles, which is covering in this region like a sternohyoid, thyroid, and the superior belly of omohyoid, which is covering this along with the muscular triangle. Now, this particular superficial one we also call them as like a lateral surface of the thyroid. This lateral surface of the thyroid has got two borders. One, you can see that this we call them as anterior border. This particular anterior border splits this particular superficial surface into anterolateral and posterolateral surface. Which one is seeing here, this superficial surface we can call them as anterolateral surface, and the one which is related to the posterior side we can call them as posterolateral surface. Posterolateral surface is related to this particular border, we call them as posterior border. So, this has got like a apex, base, and the surfaces. This is two surfaces that you can see. This one is anterolateral and posterolateral surface, and the inner surface we call them as medial surface. That means if you just take these things out, this surface or inside surface which is resting on the trachea, this surface we call them as medial surface. So, medial surface and anterolateral and posterolateral surface. This border where I am putting the cursor is roughly represent the anterior border. This one which is posterior side we call them as posterior border of the thyroid gland. So, we can identify two borders of this thyroid gland. Again, this surface we call them as lateral or superficial surface. It can be divided into anterolateral and posterolateral. Posterolateral is related to the carotid sheath. This is the cross section that you are seeing from the top. So, this is a cross section, this is a back side, this is a front side. This is a vertebra which you are seeing here with the vertebral canal, and this is the front side of the neck. So, this is the front side or the thyroid cartilage side. This is the lateral side. On the lateral side, this is the side of this carotid triangle where you see the carotid content of the carotid triangle, which is internal jugular vein, carotid arteries, and the vagus nerve which is present as the content of it. And this is which you are seeing here is esophagus. This is trachea. On top of trachea, this is the thyroid cartilage that we are seeing. This is the front muscles which you are seeing here. This is the sternocleidomastoid on the side. These are the strap muscles present, tiny ribbon like strap muscles which are present to it. Now, this region which is related to the carotid sheath along with the content is known as posterolateral surface of the thyroid gland. This is related to this particular sternohyoid, sternothyroid muscle. We call them as anterolateral or superficial surface of the thyroid, which is related to the inner side, which is related to the trachea. This side, which is touching this trachea, this side we call them as medial surface or medial side of the thyroid gland. This is how it can be described. This along with that. Along with that, it has two borders. This one is a posterior border. This one, where I am putting the cursor right now, right and left posterior border. Likewise, where it is bending between this particular anterolateral and posterolateral, here we have another border projected here. This is, we call them as anterior border of thyroid glands. So this is how the thyroid gland can be described of. This is superficial surface or anterolateral, posterolateral, likewise, and the inner side mediolateral. This part we call them as isthmus. Isthmus has got two borders, superior border, inferior border, and it has two surfaces as well. These are superficial and these are deep or external, internal, just like two surfaces it has. And all the thyroid substances is covered by the strap muscles like sternum to thyroid, sternum to hyoid. These are the two muscles along with the muscles coming from the back, which is known as omohyoid, superior belly of omohyoid, which is covering these things. And this particular thyroid gland is resting on this particular tracheal ring, and on top of that we have the larynx, which is out here is the larynx. We call them as the laryngeal cartilage. We call them as thyroid cartilage, which is present between this particular trachea. This particular thyroid gland is sitting on. Now coming to this particular isthmus. So this particular isthmus, which is present in here, which is the joining between the two lateral lobes. This isthmus have got superficial surface and superior border and inferior border, and it has got external surface and internal surface. This is what you cut open, you can see that. So this surface we see that anterolateral and anterolateral and posterolateral surface, and this surface we call them as medial surface. This is the trachea, cavity of the trachea. Behind that you have the esophagus. So this is how this particular trachea is lying, and this particular isthmus is there. Sometimes we see that on top of this particular isthmus and additional lobes are there. We call them as pyramidal lobe. We will talk about the pyramidal lobe later on. Coming to the blood supply of the thyroid gland, this is what you have to remember. There are two sets of arteries commonly supplies this thyroid. We call them as superior and inferior thyroid artery. You have to know the branches where from it is coming. External carotid artery giving the branch, we call them as superior thyroid artery. This is the first visible external carotid artery branch. Inferior thyroid artery coming from below, climbing up, it is coming from the thyrocervical trunk, which is coming from the subclavian artery, right side and left side, which is sending a branch, thyrocervical trunk sending a branch. We call them as inferior thyroid artery. These are the two regular branches of the thyroid artery, one from above, one from below. So sources of these arteries are different. Along with that, we may have an additional branch. We call them as thyroid ema artery, which may be direct branch of the arch of aorta, or may be coming as a branch of common carotid artery, or may be coming branch as a brachiocephalic trunk itself. So this particular thyroid ema artery is an inconsistent branch which is supplying this particular isthmus from the inferior surface or inferior pole of the isthmus. So if it is there, it's a trouble branch whenever you are going to deal with the surgery of this thyroid artery. So thyroid ema is an inconsistent branch which is also present in some of the individuals. If it is present, we have to be careful because it's a trouble bleeder which is present during surgery. But anyways, we are sticking to this thyroid artery, superior and inferior. These are the more consistent or deconsistent branch of thyroid arteries. Likewise, the arteries, we have the branches of the veins. We have these three sets of veins are there: superior, middle and inferior thyroidal veins. So we have three veins which is taking the blood from the thyroid glands. Superior and middle drains to this particular external carotid vein. Internal jugular vein, and this inferior drain to the left brachiocephalic vein, right side and left side. So this particular thyroidal vein which is draining this particular thyroid gland, which is draining to this particular three sets of veins: superior, middle and inferior. Now here is a relative small catch about this particular vein. Before this vein starts, they makes a plexus. We call them as thyroidal venous plexus. So this particular thyroidal venous plexus happens to occur into the substance of the thyroid gland. That means within this parenchyma of the thyroid gland, this thyroid vein makes a plexus. We call them as thyroidal plexus. Then it forms the veins afterwards. Now this thyroidal plexus is covered by the true capsules of the thyroid. Then it is covered by the false capsule or external capsule of the thyroid. So this particular thyroidal venous plexus, which is present deep inside the parenchyma of the substance of the gland. Now likewise we have a similar kind of venous plexus within a gland, we call them as the prostate gland. Now in the prostate gland as well we have the prostatic venous plexus. The difference between this thyroidal venous plexus with the prostatic venous plexus is that thyroidal venous plexus happens to occur within the substance of the gland, whereas this prostatic venous plexus happens to occur between the true capsule and the false capsule. There is a difference between them. Surgically, they are significant whenever you are going to do the surgery. But anyways, other than that, we have no problem with this thyroidal venous plexus. So, with this particular thyroid veins and the thyroid arteries, these two you have to keep in mind. Other thing which we commonly see as an exam question in this particular thyroidal arterial relation with the veins, with the nerves. Now the thyroid gland is related to the two nerves which is passing by, which is going to supply the larynx of voice box. One is known as a recurrent laryngeal nerve, other is known as superior laryngeal nerve, which is a branch of external laryngeal nerve. So this particular thing which is related to this particular superior thyroid artery, you see that this is superior thyroid artery. So this superior thyroid artery is accompanied by a superior external laryngeal nerve. So this particular nerve, which is known as external laryngeal branch of vagus, which is going to supply this particular muscles of the larynx. Now this particular vagus branch, which is known as external laryngeal nerve, is close by to this particular gland, or close by to this particular glandular artery. We call them as superior thyroid artery. Likewise, we have a branch, we call them as recurrent laryngeal nerve, which is also a recurrent branch of vagus, which has an intrigue relationship with this particular inferior thyroid artery. So these two thyroid arteries have a close relationship to the nerve supply of the larynx. Now, how does these things signify us? Now, if you are going to do any surgery related to this thyroid gland, we have to cauterize or we have to catch this particular arteries. So, if you are, say for example, you have a thyroid cancer or any diseases where you cannot keep this thyroid gland, so you have to remove the thyroid gland. Now, to remove the thyroid gland, we have to cut that particular thyroid gland and remove that. Now, if you are going to remove that, then we have to stop the blood or vessels which is going through or coming out of the thyroid gland. So, we have to clamp these arteries. So, whenever you are clipping this, we are having a close relationship with the nerves. During surgery, we may mix up with these nerves and accidentally we can damage these particular nerves. So, if you damage any of these particular nerves, which is going to end up in losing the nerve supply to the larynx. So, if you lose the larynx nerve supply, that is going to compromise the voice. So, if it is unilateral, if it is bilateral, compromise of this particular larynx may happen or musculature larynx functions may happen. So, that is why you have to be careful enough. So, this relationship of the thyroid artery with these laryngeal nerves, that we have to understand that what laryngeal nerve is related to which set of thyroidal artery, superior thyroidal and inferior thyroidal. That is what we have to keep in mind. So, this particular superior thyroid artery is related to this particular external laryngeal nerve and inferior thyroid artery is related to the recurrent laryngeal nerve. Now, both of these particular laryngeal nerves going to supply the muscles and as well as going to supply the sensory supply to the larynx. That means touch, pain, temperature, sensation on the inner side of the larynx, they are going to supply. So, during surgery, we call them as thyroidectomy. For example, if you are just like going to deal with this, we have to be careful not to damage this. So, there is a catch on doing this surgery. Whenever you are going to clip this artery, during surgery, we have to clip close to the gland out here. So, whenever you are going to ligate this superior thyroid artery, we ligate it close to the gland, because at the close of this gland, this is little bit spaces we have intervened by this particular tissues which is there. So, in case of the ligation of superior thyroid artery, we ligate it close on the upper pole of this particular or apex of this thyroid gland. Whereas, in case of the laryngeal, in case of the inferior thyroid artery, if we are going to clip it, we clip it away from gland or away from base. So, we clip it down towards close to this particular region. So, clear from this base of the thyroid gland and then we reach to this lower part and then we clip it to avoid this particular damage or incurrent damage to this particular laryngeal nerves. So, this lateral laryngeal and this particular external laryngeal, these are the two things that you have to keep in mind whenever you are going to see those surgeries. So, this relationship is sometimes or many times we see that given in an examination, like relationship of these thyroidal arteries superior and inferior with this laryngeal nerves and the courses which is coursing along with this particular neck region. So, this is what you have to keep in mind regard to this gland itself. Coming to this particular lymphatic drainage. So, this particular lymphatic drainage of the thyroid gland comes to these particular groups, we call them as superficial lymphatic drainage, and then we go for deeper group. So, they eventually drain to this particular deeper group of cervical lymph nodes, but initially they drain to the superficial like neck lymph nodes, we call them as pretracheal group of lymph nodes. From the pretracheal group of lymph nodes, they travel around this particular longitudinal group of lymph nodes which is running along with this internal carotid artery. So, we have this internal we running along this internal jugular vein. So, along with the internal jugular vein, we have the deep set of the veins which is longitudinal running. So, from this pretracheal group, it is draining to this particular deeper group and eventually draining to this particular thoracic duct right side and thoracic duct on right lymphatic duct on the right side, thoracic duct to the left side. So, this is how. So, superficial to deep group of lymphatic channels. Superficial group we call them as pretracheal, paratracheal group of lymph node, and eventually they drawn to the deep cervical group of lymph node. Deep cervical group which is known as along with the internal jugular vein which is jugular group of lymphatics. So, superficial group first, then goes to the deeper, and eventually from the deeper they drain to the lymphatic drainage group which is right lymphatic duct and then left side to the thoracic duct. So, this is how this particular gland is draining. This is what we have to keep in mind regard to this particular thyroid gland. Now, this particular thyroid gland, besides this particular thyroid gland that we have mentioned in this particular regions, we have to know a little bit about these borders. Now, as we have mentioned, the thyroid gland have got two borders. So, we have this anterior border which is can be visible here, and we have the posterior border. This is related to the posterior side. Now, this particular posterior border to this is having an importance. What importance? The posterior border related to the gland. You see that the posterior border, we have a tiny gland present to it. We have this gland which is running here, we call them as parathyroid gland. So, the posterior gland is housing this glands, we call them as parathyroid glands. And along with this parathyroid gland, we have this anastomosis of the right side and the left side superior thyroidal artery takes place. So, we have this particular thyroid artery of this particular right side, and we have this particular superior thyroid artery left side. So, right side and left side makes an anastomosis around the superior border of isthmus. This is the anterior branch, and it has a posterior branch as well from this particular superior thyroid artery. The posterior branch of superior thyroid artery which is running on the posterior side and related to this posterior border of the thyroid gland. So, this posterior border of the thyroid gland which has got a location of this gland which is number one important feature, which is having this gland. What gland? Parathyroid gland. There are group of parathyroid glands are there, will be coming into it. So, we can find the gland along with the posterior border of it, and other than this we have this anastomosis of the posterior branch of superior thyroid artery right and left runs into this particular region. So, the posterior branch of this particular superior thyroid artery right side and left side, the anastomose. So, you can see this anastomosis taking place between the right side superior thyroid and left side superior thyroid, they are extending here. Similar to that, we have the inferior thyroid artery right side and left side, they also make an anastomosis at the inferior border of the isthmus and they end up into this posterior border. So, this posterior border of the thyroid is clinically, surgically important than that of anterior border. Posterior border, we have this particular gland which is placed inside. What gland? We know the parathyroid gland, and along with that we find the blood supply which is superior thyroid artery anastomosis taking place between this particular region. This is what you have to keep in mind regard to this thyroid gland. Now, coming from this thyroid gland, we are moving to this particular parathyroid gland. So, we learned about parathyroid gland. There has a source from different kind of branchial pouch or pharyngeal pouches, third and fourth pharyngeal pouches yielding this particular parathyroid gland. We have two sets of parathyroid gland are there. One is known as superior parathyroid gland, one is known as inferior parathyroid gland. So superior parathyroid gland and inferior parathyroid gland, they can be found into the posterior border of the thyroid gland. So where you're going to see the posterior border, which is present in the posterior side of the thyroid gland. So this is the posterior border of the thyroid gland, where you can see this particular fat droplets. It looks like a fat droplets. This particular element, we call them as parathyroid glands. So there are two of them. If it is above, we call them as superior. If it is below, we call them as inferior parathyroid glands. So this particular inferior parathyroid gland is more consistently seen than that of superior parathyroid gland. Usually we see that one pair of the superior, one pair of inferior parathyroid glands are there. It could be more even. Now this particular parathyroid gland is supplied by an artery which is more consistently inferior thyroid artery. So this inferior thyroid artery, which is consistent blood supply to this particular parathyroid glands more frequently. Superior also can supply, but we see that more consistently mainly supplied by the inferior parathyroid arteries. These are also endocrine glands which is present to this particular gland. So whenever you are removing this thyroid gland, this particular gland is inevitable. If you are totally removing the thyroid gland, you are removing this particular parathyroid gland as well. If you remove this parathyroid gland, the balance which keeps this particular parathyroid hormone is the calcium, which will be deficient. So if you remove this parathyroid gland along with this particular thyroid gland, we have a disease, we call them as tetany. So which is kind of like a clinical thing that you are going to learn in physiology, in pathology and medicine as well. So this particular parathyroid gland can be found in the posterior border. So posterior border during examination, it's been asked by examination whenever you're picking up the viscera, what happens in the posterior or what special feature posterior border has on the thyroid gland that we are seeing here. Anterior border, which is demarcating between the lateral or anterolateral, posterolateral. Posterior border, which is can be easily identified by this one. Posterior border is blunt or kind of like just like posterior border of the lung. You remember the anterior border of the lung is sharper and posterior border is blunt. So this posterior border of thyroid gland is blunt, anterior border is sharper. Whenever we're seeing this anterior border, which is sharper, you can see that the sharp anterior border, whereas posterior border is kind of like a more like a margin, which is blunt margin. And thyroid gland develops from this particular content which is coming from the floor of the mouth. We call them as thyroglossal duct cyst or thyroglossal cyst. So it develops from the floor of the mouth, which is developing like a structure like this. So we call them as, we have a junctions of this anterior 2/3 and posterior 1/3 of this particular tongue, where we call them as foramen cecum. So that's the old house of the thyroid gland. So tissue which was present on the foramen cecum, which is the dot in the tongue, which goes inside or invaginates and drops down like a tunnel. That particular tunnel which is dropping from this base or side of these things, we call them as thyroglossal duct. Now this particular thyroglossal duct comes down and reaches to front of the neck, and then it splits into two branches, right side and left side, makes these two lobes of the thyroid. And rest of this particular tract, which is normally vanishes. So this thyroglossal duct is nothing but the temporary connections between the thyroidal source or the beginning point of the thyroid gland and this particular end result or end point of the thyroid gland migration. So thyroid gland starts developing from this floor of the tongue and it migrates down to the neck. Now this particular migration tract, we call them as thyroglossal duct, which is temporary. This thyroglossal duct should not have any trace. It should normally absorb completely. If it fails to absorb, it can create a cyst. We call them as thyroglossal duct cyst. So that particular thyroglossal duct cyst is an ectopic or kind of abnormal finding. It may be present on the tongue if it is present on base of the tongue or in front or below this hyoid or infrahyoid or in front of this particular front of the neck, anywhere it may be present, or may be present as a rudimentary thyroglossal additional lobe. We call them as pyramidal lobe. So the thyroglossal duct, which could be a midline cyst, which is present as a embryological remnant of the thyroid development. Thyroid develops from the point, we call them as foramen cecum. So this is about the thyroid gland. To summarize the thing about the thyroid gland, it is kind of like endocrine gland, have got two lobes, right lobe, left lobe and isthmus in between. It has two capsules, true and false. True capsule is deeper, false capsule is outside. True capsule is having a ligament attachment to the trachea. We call them as ligament of Berry. That makes this thyroid gland capable of moving up whenever you are swallowing or degluting. Then this thyroid gland isthmus, which is having two surfaces, external, internal, has got two borders, upper and lower. This thyroid lateral lobe have got like feature, we call them as apex and the base. It has got like two surfaces, we can solve them as medial surface and lateral surface. Lateral surface is anterolateral and posterolateral. It has two borders, anterior border and posterior border. Now it has got two blood supply, superior and inferior thyroid artery, and three sets of veins draining that. Superior thyroid artery, inferior thyroid artery, both of them are closed by related to the nerves which is going to supply this particular larynx. We call them as superior laryngeal and recurrent laryngeal. Superior laryngeal and recurrent laryngeal close by related to this gland makes this gland difficult while you are doing surgically opening this, not to injure those particular nerves. We have to be careful about not to damage those nerves. If you damage those nerves, it going to compromise the functions of the larynx, either voice functions or sensory or motor, both of them could be compromised. Now this particular superior thyroid artery is making an anastomosis at the superior part of this isthmus and as well as posterior border of the isthmus, posterior border of thyroid. Posterior border of the thyroid is also gives a location site for the lodgement of the parathyroid glands. Parathyroid glands, there are two of them, superior and inferior. Superior and inferior is supplied by the consistent blood supply, inferior thyroid artery more frequently rather than superior thyroid arteries. Parathyroid gland is embedded basically within this particular thyroid gland, and source of the parathyroid gland and development of the thyroid gland itself are important. And other note about this particular entity, we call them as pyramidal lobe of the thyroid. It's nothing but this particular thyroglossal duct cyst, which maybe the lower part is not absorbed properly. It can create a lobe-like structure which is present. So thyroglossal duct, which is a track through which this particular thyroid tissue migrates from its floor of the tongue to this particular neck region. Normally it should not have any trace. If it fails to regress, it can create some kind of ectopic positions of the thyroid, which could be any point between this base of the tongue or the foramen cecum to this neck region, or we see this thyroid gland may be present giving an additional lobe. We call them as thyroidal lobe. Addition to this superior thyroid and inferior thyroid artery, we may have additional branch. We call them as IMA artery. That is a trouble bleeder if it is not taken care of during surgery. So this is about the thyroid lymphatics. Superficial, deep. Superficial is pretracheal, paratracheal. Deeper is along with the internal jugular vein, which is wrapping around, spiraling around, eventually draining to the thyroid right side to the thyroglossal duct or thyroid thoracic duct, and left side right side to this particular right thoracic lymphatic channels. This is how this particular thyroid gland is draining into. In regard to these capsules, false capsule and the true capsule do not have anything in between. The veins, which is three sets of them, makes a plexus, we call them as thyroid plexus. They are present within the parenchyma of the thyroid gland. So this particular parenchyma of the thyroid gland, venous channels, and then we have this true capsule of the thyroid, then we have the false capsule of the thyroid. We have a specimen like trachea, esophagus with the thyroid in front with the thyroidal muscles inside. This is how these things looks like. This is a trachea, voice box, larynx, which is present inside to it, which is opened in here, which you can see there as well. What you are seeing here is the esophagus, not cut here, and this is the trachea which is present in front here, and the larynx box, voice box present inside. Now we have a separate specimen of the thyroid, which is like this. So you can identify this particular thyroid gland. This middle line is the bridging tissue, isthmus. This is the lobes of the thyroid gland. So parts of the thyroid gland, two lateral lobes and isthmus, 1 and 2. This is this part, we call them as lateral lobe. It has a base, it has an apex. This is a base, this is the apex. This is, you can see, sharp anterior border. This is blunt posterior border. So this particular thyroid gland, along with that isthmus, wraps around this particular thyroid gland itself, like trachea itself. So you have the trachea placed to this side, which is wrapping these things. That's why you are going to hold this particular thyroid gland like anatomical position like this. So this posterior border should be facing towards you, and you can see this posterior border have a blood vessels as well, superior thyroid artery, and this particular thing which is present like this, you are holding this in anatomy. So carve it likewise, you are assuming this is a trachea present and you are holding it. So this is the anterior border sharp, posterior border blunt, which is the location site for the lodgement of the parathyroid gland, superior, inferior, and the anastomosis between the superior right side and inferior right, superior right and left thyroidal arteries present to it. And isthmus have got external internal surface. This is what you are seeing here is the superior border, inferior border. Coming to the surface of the thyroid gland, this is superficial anterolateral, this is the posterolateral. So this is related to the carotid sheath or carotid content of the carotid sheath, and this is the whole posterior border. So this is how you will be holding this anatomically.